Look, we'd really like to thank you for joining us for our National Indigenous Health Workforce Leadership Conference. My name is Chelsea Bond, and this is Condi Canuti, my beautiful sidekick.
Yes, that's right.
We have the pleasure of being your MCs for today's event. We'd both like to acknowledge the Turrbal and Yagara people, particularly want to acknowledge Dr. Chris Baker, a Yagara man here, but also any mob here that have bloodlines to this country. We certainly pay our respects. This conference has been convened as a part of a body of work that we are undertaking as a Lowitja-funded research project called Moving Beyond the Front Line, which is about examining the critical success factors for enabling Aboriginal and Torres Strait Islander leadership across the health system via the career trajectories of the alumni of the University of Queensland's Indigenous Health Program, who today work in various leadership roles throughout the country, and I think every one of us on stage is also a graduate of the program. It is thus fitting that we open the event today with an acknowledgement of country and an opening of today's event from Aunty Lorian Hayes, who's a graduate of the program and has enjoyed a more than 50-year career in health, which first commenced in 1967 as a trainee nurse at Barcaldine Hospital. Aunty Lorian is a proud Bidjara woman and was one of the early graduates of the University of Queensland's Indigenous Health Program, and is currently nearing the end of her PhD journey within the Faculty of Medicine at the University of Queensland also. Please make Aunty Lorian welcome.
Got to calm down a bit because I'm short. There we go. Thank you, Chelsea and Condi. I've been asked to do an acknowledgement to country today, and I gave it some deep thought and I accepted. And today we stand in footsteps millennia old. May we acknowledge the traditional owners whose cultures and customs have nurtured and continue to nurture this land. The Turrbal and Yagara people, but the Turrbal are north of the Brisbane River. The beautiful homelands of the Turrbal people stretch from the North Pine River south to the Logan River and inland as far as Moggle. The Turrbal people itself is located specifically in what is now called Brisbane CBD, the name for which was Meanjin. I acknowledge the people and the traditional owners of the land where we gather today and recognise that this has always been under the custodianship and respect that these lands are a place of age-old ceremonies of celebration, initiation and renewal, not forgetting that the Aboriginal people's living culture has a unique role in the life and their respective regions within this area. The Turrbal people have and still continue to identify strongly with their ancestral lands, along with their language, the customs, the culture, their stories, songs, dances, and histories associated to their grand and wonderful country. I pay my respects to all elders who have passed and to the elders who are present here today, and to those emerging community leaders of today. I wish you well as you have a long journey ahead of you. I also extend my respects to the Aboriginal and Torres Strait Islander people who are here today. I offer gratitude to the Indigenous people who carve the trail for the pathway and the footprints that I have tried to follow. I admire the custodians and the authors of such rich source of knowledge and literature that has enabled me to draw upon throughout my journey. I pay tribute and honour an elder who before her passing always said to me, "Never forget the little children." This statement has always been with me and has helped me to guide and direct my journey, which in turn has enriched my life as an Aboriginal person. During my early years as a student, I was invited to sit on a log under the trees located on Turrbal land at the medical school in Hurston in Brisbane to engage in amazing discussions with a group of elders who asked, "What is knowledge? How do you get it?" My response was, "Knowledge is acquired through learning. Wisdom is knowing what to do with it. I guess to put it simply, knowledge is knowing that a tomato is a fruit, but wisdom is knowing not to include it in a fruit salad. I guess some people do. I recall a reference made to an audience by Paulo Freire, and Freire states, "It is a joy to work with people whose own illiteracy is with language." This is not a sarcastic reply on the part of Freire. I believe that it is a statement that alludes to the power of language and how it becomes, for all of us, an essential challenge and responsibility to be able to hear each other's embodied cultural knowledge as part of promoting social and educational transformations relating to what I have in my area that I specialise in is fetal alcohol spectrum disorders. I ask 3 questions from a poem written by T.S. Eliot, Choruses from the Rock. And where is the life that we have lost in living? Where is the wisdom that we have lost to knowledge? Where is the knowledge that we have lost to information? I ask you all, how can we as individuals or as a collective make a point regarding the necessity to rethink how we teach each other? Do we make instructional and cultural practices in order to make our work in these respective fields more effective? We all devote a large proportion of our discussion specifically in addressing issues of difference, pedagogy, curriculum, and learning and cultural practice. We must then consider the roles of educators in bringing about a cultural and educational change. The success of this change calls for sacrifices and honesty and collective desire to do the right thing for all. Communities, parents and or families, educators, clinicians have all a role to play. Quite often we expect parents to make the first move, and this is so, but then educators and clinicians must play their part to support the communities. I was told many years ago as an excited undergraduate student who wanted to research on the specific area of fetal alcohol syndrome that it would not be supported if I went ahead with this topic and was backed up. It is ethically and morally wrong to do such research that will stigmatise the mother and the child. A group of elders who stated, hang on, wrong page. I eventually went ahead and did my research, and during the next 21 years, I have continually had great interest in public debates with paediatricians, GPs and other health professionals about such stigmatisation. Rolling Thunder, a great Cherokee chief, stated, "You can't just sit down and talk about the truth. It doesn't work that way. You have to live it and be part of it, and you might get to know it." I hope you all enjoy the conference today as we remember the knowledge that we have gained throughout our individual journeys and how this gained knowledge has transformed and inspired us within our roles as leaders, mentors, educators and professionals within our communities. And let me conclude by thanking you and thanking the organisers of this event in inviting me to participate in this important and historic occasion. Thank you and enjoy your journey to gain new knowledge. Thank you.
Thank you for opening this event. It's fitting here that we're in Spring Hill. Spring Hill is the place in which the first Aboriginal Medical Service here in Brisbane was servicing this community of this region when it first was established. But not far from here is Boundary Street, the place in which blackfellas, that marked the place where blackfellas could not come into the city after dark and on Sundays. It's fitting here that a group of mostly blackfellas are negotiating, having conversations around how we transform those boundaries in the health system and transform our health outcomes for our mob. I also want to acknowledge Aunty Lorian as one of the early graduates in the Indigenous Health Program, but also someone who isn't with us today, Aunty Bubby Smith, whose artwork has been re-envisaged by Casey Coolwell from Taboo Designs for this conference event. Now, our agenda for today, we've got a couple of agendas really. One is to showcase and highlight the Indigenous health workforce research that has been undertaken across the country, supported by the Lowitja Institute. And we wish to acknowledge Mr. Romilly Mokak, the CEO, who has also joined us today. We thank the Lowitja Institute for their continued commitment to supporting Indigenous health workforce leadership. The other agenda we here is to extend the dominant discourses around Indigenous health workforce beyond that of aspiration and capacity building, to think about Indigenous leadership, excellence and transformation across the health system, an everyday thing. So we've convened today some critical dialogues that we encourage you to participate, either in the room or online via our hashtag. Before I hand over to Condi to do the housekeeping, see how we've transformed the gender roles already. I'd like to also acknowledge Professor Bronwyn Fredericks, our PBCIE at the University of Queensland, for joining us today and for your profound contribution as a leader in higher education, but also within health. We'd like to thank the Lime Network. They'll be live streaming one of our Keynote plenaries and the Changemakers panel today. We'd also like to thank Professor Sean Ewan, and the support from Melbourne Poach and the University of Melbourne with today's event.
Unfortunately, Mr. Ken Wyatt couldn't be here with us, but he has prepared a short video for us to, in his absence. Just a bit of background on Ken Wyatt. He's a proud Noongar, Yamata and Wangai man and was elected in 2010 as the Federal Minister for Hasluk, the first Aboriginal House of Representatives. And in 2015, Ken became the inaugural First Nations member of the Federal Executive after being sworn in as an Assistant Minister for Health. And in January 2017, he again made history as the first Aboriginal Minister to serve in a federal government after being appointed Minister for Aged Care and Minister for Indigenous Health. So we might just get that, Blake, get that video up now.
Hello and welcome. I acknowledge the traditional custodians of the land on which you are meeting, the Turrbal people, and pay my respects to elders past and present. I'm disappointed I can't join you in person today, but I'm grateful to bring you this message. As the Minister for Indigenous Health, one of my highest priorities is to grow the First Nations health workforce, to support your professional development so that our brothers and sisters receive the best possible care. As I said recently, I want to see our elders regularly live to 100 or more. And that focus is not mine alone. In August, all Australian governments, federal, state and territory, agreed to work with our First Nation leaders to develop the National Aboriginal and Torres Strait Islander Health Workforce Plan. This plan will focus on significantly increasing the number of First Nation doctors, nurses and health professionals, including allied health professionals. The potential to improve the lives of our people on country and in remote communities makes this a landmark opportunity. This transformation is well underway and you can expect further announcements on bolstering the local Aboriginal health workforce in the months to come. In the meantime, rest assured, the plan will deliver more First Australian doctors, nurses and health workers on country and in our cities and towns. We know from other countries with significant Indigenous populations that improvements in health are directly linked to greater participation by Indigenous people in the health system. Achieving the best possible healthcare for First Nations people and making real progress on closing the gap also relies on the broader health system, understanding the importance of people in this room today. And for services to be effective in improving Aboriginal and Torres Strait Islander health, they must operate with a fundamental understanding of and respect for First Nations culture. It is this workforce that can provide true culturally safe support and care for our people, our families and our communities. Growing the First Nations health workforce has multiple benefits. It means more jobs for First Australians across the country, which in itself is a very good thing. But importantly, it will put us in a much better position to tackle the chronic diseases like rheumatic heart disease and diabetes, which are tragically far too prevalent in Aboriginal and Torres Strait Islander communities. Many believe that progress towards closing the gap will increase when we remove the barriers to early detection of chronic disease. Those barriers are lack of awareness of the role of primary health care, how welcoming services are to Aboriginal and Torres Strait Islander people, the patient's relationship with healthcare providers and how much they're trusted, and communication issues. Nurses and doctors without the knowledge and skills to interact with Aboriginal and Torres Strait Islander people simply cannot provide them with adequate services and can contribute to reducing their access to appropriate care. First Nations people are more likely to understand, respect and use services that are provided in a culturally appropriate way. That's why our government is supporting 4 key Aboriginal and Torres Strait Islander health groups to develop not only the First Nations workforce, but to increase the cultural capability of the broader sector. We know this can work. This year, the Remote Area Health Corps is making a decade of service. Since 2008, the Health Corps has placed doctors, nurses and dentists and others in the Northern Territory communities to combat critical health workforce shortages and deliver life-changing care and support. Thousands of local residents in more than 50 communities have benefited, and without the Health Corps, many locals would have to wait for services, risk going without, or travel great distances off country to get the right care. From 100 placement in its first year, the Health Corps has grown to nearly 700 this year. Aside from the satisfaction of giving much needed treatment and care, the overwhelming message from the health professionals involved has been the value of enduring friendships and the privilege of sharing in First Nations cultures. Indeed, almost 80% of the participating health professionals are returning to undertake additional placements across the Territory. As we build the Indigenous workforce and foster First Nations doctors, nurses and health workers on country, the Health Corps will continue to play a significant role. While these bodies of work progress, a range of other measures are already making headway. And they're making headway in transforming healthcare, increasing the number of First Nations specialists, medical trainees, and specialist posts in the Aboriginal and Torres Strait Islander health settings is strongly supported by the government's review of the specialist training program. And this is reflected in new funding agreements through until 2020. Colleges and universities are also backing efforts, and the statistics are heartening. Last year, 44 Aboriginal and Torres Strait Islander medical students graduated, up from 35 in 2016, and 234 nursing, midwifery and allied health students graduated, almost 100 more than the previous year. In addition to building an effective health workforce, the knowledge and skills gained improve the health and welfare of individual students, which have flow-on effects to their families and communities. Separately, the Hearing for Learning initiative is developing a network of 40 ear health warriors across 20 communities. These warriors are local people, speaking the local language and living within and communicating directly with local parents and families. Their work is supported by fly-in, fly-out ear specialists, and ultimately we will be protecting the hearing of up to 5,000 children, transforming their lives and setting them up for success. As I've emphasised before, I believe that modern day warriors for both well-being, both within families and as health professionals like yourselves, are crucial in forging a better future for our people. On a final note, as you begin today's deliberations, the opportunities for leadership roles for First Nations people in the health system have never been greater. Aboriginal and Torres Strait Islander health is now on the standing agenda for all future COAG Health Council meetings. The health workforce plan is underway. The transformation has begun. So I thank you all for what you do, for your commitment, and in the journey of walking together to create a better future for young Indigenous Australians who will consider a career within the health workforce.
Thank you. Now, I want to assure you that today is not just a talk fest, but it is an opportunity for us to develop some critical dialogues on the eve of a new national Aboriginal and Torres Strait Islander health and medical workforce plan. These conversations today will help inform a policy brief to capture the conversations, but also reimagine the capabilities of Indigenous peoples. Now, much of the Indigenous health workforce discourse was constructed when there were none or perhaps one of us sitting at the table. With an Indigenous Health Minister at the helm and health warriors in this room, we're excited about the new possibilities moving forward, but also moving beyond the front line. It is now my great pleasure to introduce our first keynote, someone who has had a critical role in the careers of many blackfellas in this very room, including myself. Of course, I'm talking about Professor Cindy Shannon. Professor Cindy Shannon is a descendant of the Ngugi people from Moreton Bay. As you may be aware, Professor Shannon was the former Pro-Vice Chancellor of Indigenous Engagement at the University of Queensland. Over 20 years ago, she guided the development and implementation of Australia's first degree-level program that specifically targeted Aboriginal health workers, of which I was a graduate of. Now, there's a saying that you can't be what you can't see, and I consider very fortunate that at 17 years of age, I saw a black woman leading an Indigenous health program as an associate professor. And as of next year, I will be able to call myself an associate professor at that same institution. And I wish to personally thank Professor Shannon for enabling that. Professor Shannon has created the opportunities and conditions for our mob to thrive across the health system, but also in her presence has transformed the ways we think about health and innovated health service provision, particularly in the area of urban Indigenous communities, ensuring that we're not overlooked, but also leading the charge in advancing a strength-based approach to Indigenous health, of which many of us have picked up and run with today. Professor Shannon is now at QUT and leads the Nulawitja Institute's Indigenous Health Workforce Research Program. Could you please make her welcome?
Sorry. Good morning, everybody, and thank you very much, Chelsea, for that very, for me, humbling introduction. I'm absolutely delighted to be here today, and before I begin, I want to acknowledge the Turrbal and Yagara people and all my brothers and sisters who are here today. As Chelsea said, I'm a descendant of the Ngugi people from Moreton Bay region, and I pay my respects to our elders, past, present, many emerging in the room today, and I also want to pay my respects to the elders who and the people who are no longer with us but who played an enormous and significant role in what I'm going to talk to you about today. I also just want to congratulate Chelsea, Condi and the rest of the team and the Lorian Institute on funding this, because it's a very, very significant event, so thank you. Now, I've got to get myself organised here. So today, really what I'm going to do with you, there'll be a little bit of my research over the years woven into it, but it is really much more of a personal reflection. And I want to, I hope not bore you, but I think there are some very detailed accounts of the history of the Indigenous health program that are not known, and I want to walk through a little bit of that. Some of the lessons that I've learned and I think have informed Aboriginal health, and also the significance, as I see it, of the results of that program. And Chelsea mentioned that artwork that Aunty Bubby Smith, one of our first students, did, and I very clearly remember sitting with Bubby and working through with her. She just did it so easily, and she was so talented. But the meaning that underpins that logo is extraordinarily reflective of what the program was about. And don't anyone underestimate the phenomenal symbolic outcome of that logo being allowed to be used on a University of Queensland business card, letterhead, promotional material. I mean, that was breaking ground in 1992, I can tell you. There are all sorts of rules around use of brand. So this is a busy slide, and I'm sorry, I'm going to take a few minutes to go through it because I've kind of tried to align my own personal journey in employment with what's been happening in Australia in terms of policy at the time and what the Aboriginal health workforce looked like at the time. And I'll just walk through each of these as quickly as I can. But I started my career in the Department of Aboriginal Affairs, and from that period of 1980 to 87, as you know, it was the era of self-determination for Aboriginal and Torres Strait Islander people. We didn't yet have, despite 200 years of colonisation, an Aboriginal health plan. We had no national strategy. We had a loose 10-year plan that was developed under the Whitlam government, and that was really the only thing that had been embedded in Aboriginal health nationally. So it's fair to say very little focus on workforce. The first graduates that were starting to come out of universities were largely doing social work, and there was no such thing as Aboriginal support units in universities at that time. And there were, excuse me, what was starting to dominate training was in the vet sector, and here in southeast Queensland, the old Kangaroo Point TAFE College played a very significant role, particularly in the graduation of welfare people with a welfare certificate, So my next move was, from 1988 to 92, I actually taught in that vet sector program. And during this period, in a policy sense, in 1989, as many of you know, the first National Aboriginal Health Strategy was released. It had a chapter in it about workforce, and that chapter very strongly focused on Aboriginal health workers and the role that they played and the need for a career structure and remuneration to be dealt with. But it also focused on the need for educating the whole health workforce in Aboriginal and Torres Strait Islander health. The Council for Aboriginal Reconciliation was formed in the early 90s, and it started to have raise some dialogue around all of Australia having responsibility, and it did lead to a little bit of debate about the role of mainstream in this area. We saw ATSIC formed in the early 90s, and that was towards self-governance for Aboriginal people and the new model of governance. And we saw the first ever national Aboriginal education policy endorsed in the early 90s, which of course led to the formation of Aboriginal units within universities and specific designated funding for Aboriginal and Torres Strait Islander education and alternate entry. So during this time, we also saw, because of the focus on workforce, the first ever Aboriginal health worker training program out of the Cairns TAFE College, and I'm going to, in a few moments, acknowledge the people who contributed to that. So that started at Certificate 3, went to Certificate 4, and there was nowhere to go beyond that. So my next role was at the University of Queensland. As Chelsea said, I came in not to head the Indigenous health program. Some of you may not know, but Sally Gould was actually appointed to that role. Sally's a very preeminent Aboriginal nurse, and on my first day of employment there, she decided she would not take the job. And the boss said to me, "Guess what, Cindy, you've got it." Knew nothing about health, knew nothing about a medical faculty, and I've said many times before, it's really important to know what you don't know, and when you don't know something, to know where to go to get it, and that was my mode of operation for the first couple of years. But during that period, we developed the curriculum for the degree, and I'm going to talk in much more length about that, but I'm just doing a helicopter view at the moment. We saw the transfer of Aboriginal health funding from ATSIC go over to the Department of Health. It was controversial, but the argument at the time very strongly was, we're not getting leverage off the health system. We're putting red, black and yellow dollars into Aboriginal health and not making anyone else accountable for funding Aboriginal initiatives. Excuse me. The Bringing Them Home report was released, and that was a very, very big moment in Australia's history because it documented and provided the evidence of the stolen generation. And we saw some areas of specific policy development, including around the Bringing Them Home recommendations, but we also saw the emergence of the first Indigenous sexual health strategy. We saw mental health plans, we saw drug and alcohol plans, and the impact of those was this diversification of the workforce into specialist roles. And so we were now creating some more workforce challenges, I guess. And we saw the abolition of ATSIC, which really to this day hasn't been replaced in any form of Aboriginal governance at the national level. I want to talk for a moment about the AMA report card, because less than a decade before that, when the Bachelor of Applied Health Science, which was the program I ran, went to faculty board for approval, we had to go through the entire university channels. The most outspoken opponent of the degree was the AMA representative, and we were accused of bringing this fine faculty of medicine down, of training barefoot doctors and bush nurses and all sorts of things, and they got a pretty good run on it for a while. Less than a decade later, the AMA were releasing a report card every year on Aboriginal health, and the focus of, I think it was a 2004 report card, was entirely the Aboriginal health workforce. So that's a really significant turnaround for a very large national advocacy body. In terms of the Aboriginal health workforce, the other thing I want to say, at the time we were designing this new course for Aboriginal health workers, we at University of Queensland graduated their first ever Indigenous doctor in Dr Noel Heyman, of course, who's also made a very significant contribution and did to the Indigenous health program as well. So, you know, that was 100 years after New Zealand had graduated their first Maori doctors, and here we were trying to grapple not only with established established workforce professions, but a whole new area of dialogue. I did leave in 2004 for reasons I'll talk about in a moment, but I did some private consulting work, and during that period I was overwhelmed by the lack of any progress in the Aboriginal health workforce area. Workforce is the single biggest input to the health system. Without it, you can have all the money in the world, you can have all the buildings that look great and have equipment, but if you don't have the workforce that's well trained and equipped, you don't get the outcomes. So I was really focused on the relationship universities should have for workforce development, and I saw some recurring messages over and over again in my role as part of the Interdepartmental Review of Primary Healthcare to Aboriginal Communities, which I was a leader in. I also did probably 20 or 30 reviews of Aboriginal health services nationally that told me this recurring thing. During this period, a lot of the things that came out of reports that I was involved in that never saw the light of day because they were fairly damning at the time of the way in which Aboriginal funding was being used in Aboriginal health, but it did lead to some of the reforms that were announced under the Close the Gap COAG announcements in 2008. And also during this period, the registration requirements for Aboriginal health workers came into being, and we saw the emergence of APRA and the, I guess, renewed debate about the future of Aboriginal health workers, the scope of practice for Aboriginal health workers, and so on. And then that fed into the accreditation requirements of training providers. Lastly, as you heard, I was PVCIE from 2011 to 2017 at the University of Queensland, and during this period we saw the National Apology to Aboriginal and Torres Strait Islander peoples and the annual reporting against the Close the Gap funding. And I think from a workforce point of view, that's led to some issues around the registration requirements of the APRA developments, but it also again diversified the workforce because we saw some new workers coming out of Close the Gap, like the outreach workers, different types of peer educators and community workers. And I think if we try and grapple with what's happening in the workforce, I think being on the front foot and doing what we did 20 years ago, we didn't have the foresight at the time about how important that would be. So that was a very long-winded overview of my personal reflection, but I wanted for a moment focus on the Indigenous health program and its achievements and then the leadership that I saw in that process. As Chelsea said, it was the first degree level type of its program in Australia. I do want to acknowledge though that the University of Sydney had a stream within a program that they offered that did focus on Indigenous health at the time. Defining who the target group for that program was difficult because it was intended to be the next step for Aboriginal health workers who did the TAFE level training, but it also wanted to have a focus on management in a primary healthcare sense. The admissions process was interesting. We ran an introductory program as well, but we had debate also about whether this should be exclusively Aboriginal and Torres Strait Islander or whether there could be a small proportion of students who were non-Indigenous, and we went for the latter, and I think it was the right decision. I think there are some people in this room and graduates of our program who are non-Indigenous who are also making extraordinary contributions to Indigenous health, and we also had small numbers of PNG and Pacific Island students who fitted in very well to the model of teaching. The developmental process, and now having been in a Pro-Vice-Chancellor's role for a number of years and seen how things go up the food chain, I have no idea how we got away with it. We should have, and we did, but knowing how important tradition is in universities, or how rigid it is, we had community reference groups in the north and south of the state who absolutely fed into the design of the course. We had a board of studies for the degree level course which had significant external representation from the Aboriginal community on it, and they really did drive what happened in probably the most conservative faculty at the, I can say that, at the University of Queensland. So they were very significant developments in the early 90s. We used problem-based learning. It was what was the most desired and impactful in terms of allowing the holistic approach to health for students to bring their lived experience of Aboriginal health and contextualise their learning within that. That was pioneering a new and emerging field of education at the University of Queensland, and has informed the graduate medical course and other programs that are now using problem-based learning. And lastly, I think our clinical placements were very selectively made in a safe way for the students, but in a two-way learning exchange as well. And our partnerships with communities for real-life problems for students to engage in were just extraordinary. And I think there's not any student who went through that program who wouldn't think that was a fantastic learning experience as an undergraduate. The significance of the program, I think, is something that I'm delighted to see people today talking about, because I think it's been underdone to date. People talk about my leadership of the program, but it wasn't me who had the vision or who had the hard discussions that needed to be had. And I really want to acknowledge and pay my respects to two people who led that early development. Firstly, Gracelyn Smallwood, who many of you know, was the chair of the Queensland Aboriginal and Torres Strait Islander Tripartite Forum in the late 80s, and she was part of the review of the Tropical Health Program at the University of Queensland that basically said, we're doing all this wonderful work in our neighbouring countries, but we're not doing anything in our own backyard. Why? And she really held them to account on that. Then the late Mick Miller, who was a very, very prominent leader in Aboriginal affairs generally, led the development of the program, and his advocacy, his leadership was second to none, and he really did drive very hard its development, and I want to acknowledge that today. I think some other lessons that we learned was the extent to which we were bringing a faculty on a journey, and we were building their capacity. I definitely underestimated that at the time, and you'd naively have these conversations thinking this is obvious, and the extent of educating and convincing that you had to do was just extraordinary. But you will always have challenges, but we did bring a faculty of medicine on a journey. I want to also acknowledge the contributions that many of our staff were early career, and I don't want to miss anyone out, but I've seen John Willis, I've seen Mark Bruff somewhere, Melissa Elkin, Melissa, I still forget, sorry, in the room, and others. Wendy's here somewhere, yep, Wendy Foley, and others who made tremendous sacrifices early in their careers as academics because of their commitment to this program and to what it could achieve. And I really want to acknowledge the sacrifices they made at a stage of their career when they made a choice, and the program wouldn't have had the success it had without them and that sacrifice. And I want to also acknowledge the extent to which the program produced outcomes for communities. So it wasn't just the graduates of the program that are the product of it. All of the work we did were real life issues in community that were solving or seeking to address problems, whether it was in an environmental area, whether it was in a health system area, a communicable disease area. We had a range of projects that just evolved in communities because of the relationship and the commitment to the problem-based learning. So I want to talk a little bit, though, about the not so good, because there were some great outcomes, and I would say it was in spite of rather than because of the university at times that we achieved some of the extraordinary outcomes. Firstly, in the external environment outside of the university, we had, you have that age-old debate about whether structure should follow strategy or strategy follow structure. But we had a situation where we had a vision and a strategy for an Aboriginal health workforce that would lead into health worker workforce that would lead into management roles. The structure of the award, the structure of the Aboriginal health worker just didn't happen. It was, I almost felt like it was unethical to keep doing what we were doing if our graduates weren't going to be recognised in a structural sense. Similarly, we were this little Aboriginal health program sitting in a tropical health program, and it got to the point where it made no sense structurally. It needed its own identity, and it needed to be recognised as an Australian Aboriginal and Torres Strait Islander program. I think with the introduction of the Aboriginal education units in universities and funding for Indigenous higher education, we got into the trouble of having to navigate the health education divide with funding. And we were providing funding for Indigenous higher education in health, but we didn't receive any of the higher education funding that came, and that became an ongoing challenge. And I think some of the policy development and shifts during the 90s that had significant workforce implications in terms of the structure of the Aboriginal health worker workforce provided challenges for a trainer that wasn't working in parallel with that. In the internal environment within the university, again, the structural change, I talked about having an Indigenous health program within a tropical health program, then it led to the formation of a School of Population Health and the opportunity to say what's the biggest public health issue in Australia or population health issue, and put Indigenous health front and centre. But sadly, at the time, the focus was very much on international public health, and I think it was a lost opportunity. I think, we can't underestimate the impact of leadership and how changes in leadership can change the way in which the support and commitment to a particular area is given. And this area should not be left to the lone black fella to lead. It's got to be a whole of institution, whole of faculty, whatever type of commitment. I think with the formation of the graduate medical program and a feeder program in a Bachelor of Applied Health Science into that program, the notion of having an Indigenous stream within that was seen as mainstreaming. It may not have been if the process had been better, but, and I think the single biggest issue was the failure to see that this program was one of the greatest assets that the faculty had, and to resource it appropriately and sustain it into the long term. So, I just want to talk for a few minutes about some of the lessons that I've learned in leadership through this journey. I think, we took a big risk, and we have to take risks, because if we wait for the system to deal with the issues in Indigenous health, we won't get there. And I think Chelsea said to me before, being bold is really important in this space, and this was right out there. But when I see the results of it, that risk was well mitigated and worth taking. Everybody who did it believed in it and was committed to it, and it's that level of commitment that also can't be the driver that sustains the program. There's got to be people leave or move on, and your sustainability is a challenge. We have to expect the unexpected. We expected to train Aboriginal health workers who'd become Aboriginal health workers in management positions. We didn't expect to see an associate professor a decade or two later. We love it. We didn't expect to see people leading mainstream health services, leading Aboriginal health at senior policy levels in the state, leading their own primary healthcare centres in communities, doing research, the whole range of outcomes that we've achieved. And I think that's been one of the great outcomes of the program. I do, as I said, really respect the sacrifices that people made, and they were extraordinary. And I think that's coupled with the extent to which resilience was just embedded in what I saw every day amongst the students and the staff, and that really did humble me many times. I think the reason we've seen a lot of the successes is because people have embraced opportunity. They've seen it. There is no better time in Aboriginal health now with what we've seen in the last few years to embrace opportunity and try new and work in new directions that weren't thought of at the time of the program. And I love the fact that primary healthcare in the mainstream is now a challenge. And 2 decades later, there's lots we can learn from what's happened in Aboriginal community-controlled health services and in the mainstream. In the Aboriginal sector, some of their primary healthcare models are leading mainstream developments. I sit on a primary healthcare network board, and I can tell you, the challenges we're facing, I think, Aboriginal services have been doing this for years, and it is second nature. The other thing is that we're seeing Indigenous graduates working in mainstream settings, and I do remember when we had our reference group meeting back in 1992, the first one I went to, one of the community leaders on that reference group said to me, "Cindy, success won't be when we've got one of our Aboriginal graduates from the program as CEO of an Aboriginal medical service. It won't be that alone. It'll be when I walk into emergency and the director of emergency in the hospital's an Aboriginal doctor." And, about 8 or 9 years ago, I see a newspaper clipping of Dr. Raymond Gadd heading at A&E at Gladstone Hospital. So, we really have to reflect on the significance of that. I'm nearly finished, I promise. Now, you'll notice that's a blank slide. And I thought about this, and I found it really hard to articulate. How far have we come? On one level, transformational, as was said to me earlier this morning. On another level, and I do not want you to try and read this slide, but this is the slide, and I acknowledge that this has been provided to me by Queensland Health, but this is the slide that tells the story of the progress with the Aboriginal health worker career structure in the last 7 or 8 years. And now in 2018, we've just had an announcement from the Minister about the alignment for the Aboriginal health practitioner competencies and the training that will be rolled out. We did the isolated practice training for Aboriginal health workers in communities 20 years ago. Had we have waited for this career structure to come out and halted any development for the Aboriginal health workforce, we would not be where we are today. And I pay tribute to every single one of you who've made the difference and who've continued on the journey, as I said, despite these slow-moving obstacles. And I really do acknowledge and admire that. So, where to from here? When I started on this journey, the motto was very much Aboriginal health in Aboriginal hands. And I think we have got to the point where Indigenous health is everyone's business. And somewhere within that, Aboriginal leadership and Aboriginal control of the agenda is still absolutely critical. So I want to conclude by acknowledging all the graduates of the program, the amazing work that I'm seeing you all do in Indigenous health, the former students who may not have graduated but have still made a difference and still done things in their community, all of the former staff of the program and the enormous contribution they made to the success of the Indigenous health program and its outcomes. And I do also want to acknowledge one of our greatest leaders in Indigenous health here in South East Queensland, in Adrian Carson, and the sorry business, as you know, that their family is going through at the moment, and remind some of you that his brother was a student in the program. So if we can just take a moment to think about that too. And thank you all very much. Again, thank you.